Imagine going into surgery for this agonizing pain, right? And the doctor finds absolutely nothing, does absolutely nothing, and you wake up cured.
I mean, it sounds totally impossible.
Completely impossible. But today, we're looking at the invisible ink of pelvic pain. Because usually, when we talk about a medical diagnosis, there's this, like, expectation of precision for you as a patient.
Right, yeah. Like, you break your arm, the x-ray shows a jagged white line.
Exactly. And the doctor just points at it, broken or not broken. It's clean, visible, highly categorizable. But you step into the world of chronic pelvic pain and endometriosis, and that x-ray machine is, well, it's effectively broken.
It really is. The diagnostic landscape is just completely murky.
And for a condition affecting roughly 10% of reproductive age women, that murkiness is a profound public health issue. We are talking about millions upon millions of people living with a daily reality that, alters their relationships, their careers, their whole quality of life.
Yeah, and the specific type of endometriosis we're focusing on today is arguably the most deceptive kind. So we're doing a deep dive into this new 2026 study from the Journal of Minimally Invasive Gynecology.
Right, and our mission here is really to figure out, does surgical excision actually work for this very specific, historically under-researched subtype, the one called isolated superficial peritoneal endometriosis, or iSPE?
Exactly. iSPE is, well, it's defined by this endometrium-like tissue that sits directly on the peritoneal surface.
And that's the thin membrane, right?
Right, the clear membrane lining your abdominal cavity and covering your pelvic organs. So it's anatomically really subtle. It forms these tiny flecks or clear blisters.
Wow.
Yeah, and it doesn't infiltrate deeply into the tissue. The word superficial is used purely in a geographical sense.
Right, which I imagine gives people the wrong idea.
Oh, totally. It gives patients the false impression that their condition is mild, but the inflammatory pain it causes is agonizing and systemic.
Okay, let's unpack this, because when most people hear endometriosis, they picture something highly visible, like large ovarian cysts or deep infiltrating disease where the tissue aggressively wraps around organs like vines.
Right, the classic textbook cases.
Yeah, but iSPE is different. I think of it kind of like invisible ink on a document. If you look at the document from a distance or, under a standard light like a typical pelvic ultrasound, it looks completely blank. You just don't see the big masses. But that invisible ink is there, completely altering the body's pain signals.
That's a great way to put it. And that structural subtlety is exactly what drives this major controversy in the medical field.
Because doctors are wondering, if you have these invisible ink lesions, does putting you under anesthesia and surgically removing them actually change your daily life?
Exactly. For years, surgery for endometriosis pain has been fiercely debated. Past Cochrane reviews, which are the gold standard for evaluating medical evidence, have repeatedly called the data inconclusive.
Really?
Yeah.
Inconclusive.
Yeah, mostly because the available studies were either too low quality or they improperly mixed all the different phenotypes of endometriosis together.
Ah, I see.
So because iSPE is so difficult to spot, doctors have really struggled to justify the inherent risks of putting a patient through a major operation.
So let's look at the setup for this new 2026 study, because the researchers set up a really fascinating comparison.
They did.
They looked at a retrospective cohort of 250 women aged 18 to 45. Every single one of them suffered from severe endometriosis-associated pain.
And every single one had clear imaging.
Right. No big cysts, no deep infiltration showed up on their ultrasounds. So they all went into the operating room for suspected iSPE.
And the critical division happens once the surgeons actually looked inside. Out of those 250 women, 158 had confirmed isolated superficial peritoneal endometriosis.
Okay.
But 92 of them had absolutely no evidence of the disease found during the operation. Their pelvic cavities were completely clear.
So we have a perfect comparative scenario. People with the exact same pre-surgery agony, exact same clear ultrasounds, going through the exact same surgical procedure.
Yep.
Some had the invisible ink, some didn't. So what actually happens to their pain after?
Well, the outcomes for the patients with surgically confirmed iSPE were striking. For overall pain improvement at the short-term follow-ups, that's 6 to 12 weeks after surgery, nearly 4 out of 5 patients saw a reduction in their pain.
Wow.
Yeah, and by the medium-term follow-up of 12 weeks to a year, that number bumps up to over 80%.
That is huge.
And looking at the long-term data, well past a year later, over 82% maintained that overall pain improvement.
Okay, over 80% long-term success sounds like a definitive victory for surgery. But wait, looking at these numbers, what about the control group?
Yeah, the control group is where it gets complicated.
Because the data shows that between 52 and 56% of those 92 women who had absolutely no endometriosis found also reported overall pain improvement. So if more than half the people without the disease got better just from being put to sleep and having a camera look around, I mean, does that mean the surgery itself is just a giant placebo? Are we opening people up doing nothing and they feel better simply because they believe they were treated?
What's fascinating here is that the statistics tell a much deeper story than a simple placebo effect. Though, you are highlighting one of the most complex phenomena in chronic pain management.
Right, because a 50+% improvement from basically nothing is wild.
It is substantial. The surgical placebo effect is notoriously powerful. But we also have to look at the psychological reassurance of a comprehensive diagnostic evaluation.
What do you mean by that?
Well, imagine living with a debilitating pelvic pain for a decade, having countless doctors dismiss your symptoms as normal, and finally a specialist takes you seriously enough to operate.
Oh, wow. Yeah.
They look inside and definitively tell you you do not have a hidden destructive disease eating away at your organs.
Ah, so it's the relief of validation. Just having a definitive answer, even a negative one, acts as a form of treatment.
Exactly. It creates a measurable biological change. That deep psychological relief downregulates the nervous system.
And your chronic anxiety keeps you on edge, right?
Right. It keeps the body in a sympathetic fight-or-flight state, which actually amplifies pain perception. When that fear is removed, the nervous system calms down and the baseline perception of pain drops.
Okay, but if the placebo effect and the psychological reassurance are that powerful, how do we know the actual cutting out of the tissue in the iSPE group did anything at all?
By utilizing multivariable logistic regression models.
Okay, statistics time.
Yeah, statisticians use these to isolate variables.
Mm-hmm.
Essentially, they hold every other factor constant, like a patient's age or their baseline pain score, to see if one specific thing drives the outcome.
And what do they find?
Having confirmed surgically removed endometriosis was the strongest independent predictor of pain improvement across every single time interval. Yeah. By the time we look at the long-term follow-up, the patients who had confirmed iSPE excised were over 4.4 times more likely to have sustained pain relief compared to the non-disease group.
4.4 times.
Exactly. The placebo effect tends to fade over time, But the structural removal of disease-causing tissue creates a lasting mechanical and biochemical change.
Okay, so a 4 times greater likelihood of long-term release clearly separates the true surgical benefit from just psychological comfort.
Definitely.
But I want to transition from these broad overall pain statistics to what this actually means for your Tuesday morning. Because saying 82% improved is great for a medical journal. But chronic pelvic pain is a highly specific hour-to-hour grind.
It's all-consuming.
Right. So how does this surgery actually alter the physical reality of living in that body?
Well, endometriosis is a constellation of highly disruptive symptoms, right? It's not just a generalized ache. So the study broke down how daily life changed by comparing specific symptom outcomes.
Like cramps.
Yeah. For dysmenorrhea, which are severe, debilitating menstrual cramps, over 82.5% of the iSPE group saw improvement, compared to just roughly 60% in the non-disease group.
That's a huge jump.
And for non-menstrual pelvic pain, which is that stabbing random pain that hits outside of a cycle, the success rate remained over 82% for the surgically treated group, compared to 52% for the control.
So the surgery is heavily impacting both the cyclic and non-cyclic pelvic aching. What about intimacy? Because deep dyspareunia, or deeply painful sexual intercourse, is a symptom that fundamentally fractures quality of life and relationships for people with this condition.
Absolutely. And the excision profoundly changed that specific mechanical pain. 69% of the patients with confirmed iSPE reported improvement in painful sex, compared to just 38.4% in the non-disease group.
Okay, here's where it gets really interesting. Because the researchers didn't just ask patients about their symptoms, right? They mapped those symptoms directly to the physical geography of the pelvis.
Right. They looked at where they found the invisible ink and tied it to what was actually hurting.
Yeah. And they found that removing lesions in something called the pouch of Douglas was strongly associated with a reduction in painful sex.
Mm-hmm.
For those of us who don't spend our days looking at anatomical charts, what exactly is the pouch of Douglas, and why does finding lesions there correlate so tightly with intimacy?
So the pelvic cavity is a very tight, crowded neighborhood.
Right.
The pouch of Douglas, or the rectuterine pouch, is the deepest pocket of space in the female peritoneal cavity. It's located squarely between the back wall of the uterus and the front wall of the rectum.
Okay, so it's really low down.
Exactly. Because it's the lowest point in the pelvis, gravity naturally draws inflammatory fluids and rogue endometrial cells down into it.
Oh, that makes sense.
Yeah, it makes it a prime gathering spot for superficial endometriosis. In this cohort, it was actually the most common location for lesions, found in over 63% of cases.
So you have these highly inflammatory, hypersensitive lesions pooling exactly in the space between the reproductive tract and the lower bowel.
Yep. And from a strictly mechanical standpoint, deep sexual intercourse involves movement and pressure against the cervix and the uterus.
Right.
If the tissue directly behind those structures is inflamed and covered in raw lesions, that physical pressure translates instantly into a sharp, deep pain response.
Wow.
So surgically excising those specific lesions removes the physical trigger being impacted.
That makes total mechanical sense. You remove the inflammatory tissue that's being bumped into, and the pain of bumping into it stops.
Exactly.
But looking at the data, there's a clear contrast. Because while cramps and painful sex had these highly consistent success rates, things like dysuria, which is painful urination, and dyschezia, painful bowel movements, they had much less reliable benefits from the surgery.
Yeah, that's true.
Why does snipping out superficial lesions fix painful sex so beautifully, but leaves bathroom-related pain unresolved for so many?
It comes back to that crowded neighborhood concept. The pathways transmitting pain from the bladder and the bowel are distinct, and superficial excision does not interrupt them equally.
Okay.
But more importantly, painful urination and painful bowel movements heavily overlap with entirely different conditions.
Like what?
Well, a patient might have iSPE causing their cramps, but they might also suffer from interstitial cystitis, which is a chronic inflammatory bladder condition, or they might have irritable bowel syndrome.
Oh, I see.
Yeah, excisional surgery meticulously removes the superficial endometriosis from the outside of the organs, but it does absolutely nothing to cure a coexisting internal bladder or bowel syndrome.
Right. So if excising the tissue fixes the mechanically triggered pain so effectively, why did roughly 20% of these confirmed iSPE patients wake up in just as much agony?
That's the million-dollar question.
Right. I mean, they went under the knife, the surgeons found the disease, they cut it out, and the patient saw zero meaningful pain improvement a year later.
The study pinpointed two major culprits for surgical failure, fundamentally shifting how we need to view pelvic pain.
Okay, what's the first one?
The first is a structural barrier, a condition called adenomyosis.
Adenomyosis. Let me try to visualize this. If the uterus is like a thick, dense kitchen sponge, superficial endometriosis is like a dark stain sitting on a countertop right next to it.
Okay, yeah.
But adenomyosis is when that dark stain soaks deep into the center of the sponge itself.
That is an excellent analogy. Adenomyosis involves endometrium-like tissue growing directly inside the muscular wall of the uterus.
Oh, wow.
Yeah, so a surgeon performing a laparoscopy is essentially coming in with a specialized surface cleaner. They can wipe the countertop spotless, meticulously removing the iSPE from the peritoneal membrane.
Right.
But they cannot scrape the stain out of the center of that uterine sponge without fundamentally destroying the uterus itself.
They clean the outside of the house, but the fire is still burning inside the walls.
Precisely. And the data reflects that limitation perfectly. When patients had suspected adenomyosis, their likelihood of long-term pain improvement from superficial excision dropped significantly.
Because the physical source of their pain was simply inaccessible to the tools being used.
Exactly.
Okay, so if adenomyosis is the physical barrier to success, what is the second culprit?
It's a neurological barrier known as central sensitization.
Central sensitization.
Right. Pelvic pain is not solely dictated by physical lesions. When a body is subjected to severe chronic pain over years or decades, the central nervous system undergoes neuroplastic changes.
Wait, it actually changes the nervous system.
Yes. The spinal cord and the brain actually rewire themselves to become hyperexcitable. They begin interpreting normal, non-painful signals from the pelvic region, like, the natural movement of digestion or a full bladder, as intense, agonizing pain.
It's like a faulty home security system.
Oh, I like that.
Yeah, like a burglar breaks into your house that represents the endometriosis lesions causing the initial damage. The alarm is blaring. Then the surgeon is the police officer who arrives, arrests the burglar, and removes them from the property, the physical threat is completely gone.
Right.
But the alarm system itself is broken, and the sirens just keep blaring at full volume 24 hours a day.
That is the exact tragedy of central sensitization. The physical trigger is gone, but the altered central pain processing network remains hyperactive.
That's heartbreaking.
It really is. These patients frequently present with a web of overlapping systemic pain syndromes, severe migraines, fibromyalgia, chronic fatigue. In those cases, a purely structural surgery won't silence the alarm.
But how are you supposed to know if you fall into this category before agreeing to a major surgery? Because nobody wants to undergo an operation if the alarm is just going to keep ringing.
If we connect this to the bigger picture, this is exactly why the clinical approach detailed in the study is vital. The clinic intentionally pre-screens patients for central sensitization.
Okay, that's smart.
Yeah, if someone presents with widespread non-anatomical pain and multiple overlapping systemic syndromes, a responsible specialist might advise against rushing into the operating room.
What do they do instead?
They prioritize neuromodulating medications, specialized pelvic floor physical therapy, and pain psychology. The goal is to calm and reset the central nervous system first before attempting a structural intervention.
So the surgery is a specific tool for a specific job, not a magic wand for all pelvic pain.
Exactly.
And speaking of tools, the study also highlights a crucial step patients can take after the surgery to protect their outcome.
Right. Postoperative hormonal therapy plays a defining role in long-term success. The data demonstrated that patients who utilized hormonal suppression after their excision had a 2.5 times greater chance of sustained pain relief.
Really? Why is that follow-up so necessary?
Because endometriosis is fundamentally an estrogen-dependent disease. Estrogen fuels the tissue, telling it to grow, bleed, and cause inflammation. So surgery acts as the mechanical removal, pulling the weeds from the garden, so to speak. But postoperative hormonal therapy, like continuous progestins, stops the menstrual cycle and deprives any microscopic leftover cells of the estrogen they need to thrive.
So it acts as a 1-2 punch. You remove the visible disease, and you alter the biochemical environment so it cannot return.
Exactly.
So what does this all mean for your daily life? Let's sort of synthesize this for everyone listening. If you are living with the invisible ink reality of suspected isolated superficial peritoneal endometriosis, and your imaging is frustratingly clear but your pain is intensely real, this data validates your experience.
Absolutely does.
It provides concrete evidence that surgical excision is not merely a placebo. It can profoundly improve your life, drastically reducing severe cramps and mechanically triggered pain like deep dyspareunia. But chronic pelvic pain requires a holistic lens. Surgery is highly effective at removing surface lesions, but it will fail if co-occurring conditions like adenomyosis are hidden in the uterine muscle, or if your central nervous system has become so sensitized that the alarm is just stuck on.
Right.
You really need a medical team that treats the whole neighborhood, not just the single house.
And, the findings of this study also force us to confront a lingering dilemma in medical research.
Oh, what's that?
We discussed earlier how the control group, the patients without the disease, still experienced a 50+% improvement rate.
Right, the placebo and reassurance effect.
Yeah. In a perfect scientific vacuum, the only way to completely separate the mechanical surgical effect from the placebo effect would be to conduct a randomized, double-blind, true placebo trial.
A true placebo trial for a surgical intervention. What would that even entail?
Well, it would require putting a symptomatic suffering patient under anesthesia, making the incisions, inserting the laparoscope, actively finding the inflamed endometriosis lesions, and then intentionally leaving them untreated inside the patient's body.
Wait, what?
Yeah, you would sew them back up just to see how their outcomes compare to the group that actually got the tissue removed.
You cannot do that.
Yeah.
You cannot open a human being up, visually confirm the source of their agony, and intentionally leave it there for the sake of a clean data set.
Exactly. It is a profound ethical impossibility. How do we demand flawless scientific proof of surgical efficacy without violating the fundamental oath to do no harm?
That's wild.
This is the inescapable limitation of almost all surgical endometriosis research. We rely on retrospective data and non-disease control groups because a true double-blind surgical placebo is ethically abhorrent.
It creates this incredible tension, right, between demanding rigorous scientific proof to justify insurance coverage and care and the ethical reality of the human being lying on the operating table. The X-ray machine for pelvic pain may still be broken. We are still navigating a murky diagnostic landscape, searching for invisible ink. But parsing out data like this, understanding exactly who benefits and why, it acts like a blacklight. It finally makes the invisible visible.
And it really forces us to rethink the very nature of treatment.
It does. It leaves you wondering if belief, validation, and psychological relief alone can physically downregulate our nervous systems enough to cure pain for half the people who experience it. I mean, how much of our healing actually happens under the knife and how much happens entirely within our own brains?